So I think we better start. I think it's a very honorable moment for us to have invited experts from the University of Florida, Wilson Children's Hospital, and Nemours Children's Service from Florida, coming all the way more than 16 hours of flight to Hong Kong at this particular time. I have been struggling with Dr. Tom Chiu, my very best friend for the last 25 years, that whether we should cancel the event, but they think that it's very adventurous. Thanks to thanks to Mr. Michael Auburn, and there's no no reason to cancel that because this is a very important moment. Why is that? Because that I think we see a very important opportunity in the future that we have more collaboration between the public and private healthcare services in Hong Kong, and also with the University of Florida and the Nemours and Wilson Children's Hospital. This particular talk, the first talk, is very important to me because last time in the audience is Dr. Philip Adana. He mentioned to us in the last visit that the best treatment for some patient with brain tumor would be proton therapy because there will be less collateral damage. That's the key message I got last time you get. And then I heard from Dr. Lau that they're going to have a proton therapy center which might be operational at the end of 2022. And then they are committed to provide some service to pediatric patients. And then we need to have collaboration. Of course, we do not know anything about proton therapy. I do not know anything about proton therapy. So I'm very indebted to our speaker today, our first speaker today, Dr. Danny Indelicato, coming all the way, not just from Florida, but from Scotland, where he was invited to give a very prestigious lecture before he came here to Hong Kong. So without further ado, I think we must start the talk. I must tell you that in the audience, a very important person. One is our CE, Dr. Tony Goh, coming all the way among his very busy schedule. Dr. CC Lau, I just mentioned. And Mr. John Lee, our chairman of our HKCH committee. And then we have Mr. Stanley Lau, one of our members of HKC, and also some other members of the two hospitals. So without further ado, let us welcome Danny to give this talk about proton therapy in pediatric brain tumor.
Thank you. Thank you for inviting me. Just the wonderful hospitality is unforgettable, and certainly the weather here is a lot better than Scotland. So today I'm going to be presenting some evidence for the use of proton therapy in children, specifically in the settings of brain tumors. And I'll try to provide some up-to-date rationale about why we use proton therapy and what kind of cases it's good for. First, just a broad overview. The image you see on your screen is a table from the American Cancer Society about 5 years ago that demonstrates improvement in pediatric cancer survival in the United States over the past 40 to 50 years. It's broken down by disease site, and you see that I have a red box around the pediatric brain tumors, specifically ependymomas, astrocytomas, and medulloblastomas that have seen remarkable jumps in survival, 30, 40% in some cases. However, over a contemporaneous time period, you see the trend in the use of radiation in pediatric brain tumors. That's this purple line specifically going down over those years. Now, that's not because radiation is not effective for pediatric brain tumors. We know that it's effective. In fact, it's probably responsible for some of those increases in survival across diseases like ependymoma and medulloblastoma. The reason we're seeing the reduction in the use of radiation for pediatric brain tumors is concern about the short and long-term side effects of the treatment. Going into what separates proton radiation from traditional radiation. This one slide on the physics that I'll show you. On the left side of your screen, on this axis, is the radiation dose. On the bottom axis is the depth of a theoretical tumor. When you fire a single proton into a patient, it travels through the patient to a depth that's determined by its energy, and then it delivers a really high dose of radiation for about 1 millimeter or smaller, and then stops immediately. The difference between this and traditional radiation is that with X-rays or photons, the radiation travels through the patient, treats the tumor, and then keeps on delivering radiation dose. You don't have this rapid fall off in absence of distal dose range. The problem with this is when you fire a single proton, it only delivers that point dose. So to get a clinically relevant dose distribution, you need to fire many protons in rapid succession so that together, collectively, over a millisecond, you get a radiation dose that spreads out to cover the size of a clinically relevant tumor, but maintains the absence of the exit dose. So here's an example of this in practice. On the left side of the screen, you see a sagittal CT scan of a thoracic spine of a 15-year-old boy with a paraspinal sarcoma. On the top part, you see this color wash, which represents the radiation dose distribution. And below it, you see that theoretical Bragg peak, as I pointed out earlier, where the radiation should travel to this distance and stop. So on the right side of your screen, you see the same boy, similar positioning, but about 9 months following the radiation delivery. And what characteristically stands out here is the thoracic vertebrae bone marrow, and that high or white signal change you see in the bone marrow is a normal fatty evolution of bone marrow following radiation. We see it commonly. That's not what I'm pointing out on this slide. What I want you to appreciate is the fact that the changes, the high signal in the bone marrow stops right here, which exactly corresponds with the predicted radiation dose distribution, and most importantly, spares this child from radiation of the heart and lungs that lie anterior. So throughout all of radiation oncology, there are two main modes to apply proton therapy. To simplify it, the first way is to leverage this dose distribution, this added accuracy, to escalate the radiation dose to a tumor. So an example scenario of this might be when you keep the toxicity in adjacent normal tissue constant, but use the precision of protons to escalate the radiation dose and intensify treatment. So a use of this clinically today is to treat skull-based chordomas, for example, to a higher dose, increasing the cure rate without causing more blindness. The other mode of application is to use the precision in proton therapy to reduce collateral radiation injury. That is, you keep the radiation dose to the tumor constant, thus keep the cure rate approximately the same, but reduce the dose and therefore toxicity to adjacent normal tissue. So an example of this might be curing medulloblastomas in children at the same rate, but decreasing the subsequent damage to the heart and lungs. So broadly speaking, in pediatric patients to this point, both the University of Florida and worldwide, we've largely focused on the mode of application number 2 in an attempt to reduce some of the toxicity in children who become survivors. So I'm sorry this didn't come out in the formatting, but of the pediatric tumors treated at the University of Florida through the end of last month, about 60% of the children we treat have brain tumors. About another 25% have sarcomas, usually axial sarcomas, Ewing sarcomas, rhabdomyosarcomas of the skull base, the spine, the pelvis, or the chest wall, and then a small mix of head and neck malignancies in children, lymphomas in children, and other miscellaneous subtypes. This is the last data we have available on the worldwide use of proton therapy in children. On this slide, which represents data from 2016, you have the number of patients treated, excuse me, I can't see them, a number of patients treated in 2016 by the year each proton center opened, and each dot represents a proton center in a different part of the world. So the European ones are in blue, Asian ones are in purple, and green are the United States centers. So we know that this is anonymous data, but the Proton Center at the University of Florida opened in 2006, and representatively, we treat more pediatric patients than anywhere else in the world by a large degree, and that's maintained through today. And using that same data set from 2016, you look at the top 10 diagnoses, which constitute over 75% of the children treated with protons, and 5 of the top 8 of the most common tumors treated with proton therapy are brain tumors, both worldwide and throughout each individual region. And when you break that down even further into the types of tumors treated at the University of Florida, you see our data since 2007. 4 of our most common, or 6 most common brain tumors, or 4 of the 6 most common tumors we treat in children are brain tumors. What is the rationale specifically? I talked about the radiation sensitivity of the developing pediatric brain. Well, to give you some idea of the scope of the injury from conventional radiation, there's a study of 285 Dutch pediatric cancer survivors who grew up following the receipt of brain radiation, and this study found that 80% developed at least one adverse event, and these weren't just minor side effects or complications. In fact, 45% of these survivors had at least one that would be characterized as severe, life-threatening, or disabling. So specifically to look at cognitive impact of radiation and how that might be improved with proton therapy. This is a child with a posterior fossa ependymoma. On the left side of your screen, you see the radiation delivered with protons, and on the right side, you see radiation developed with an advanced X-ray technique called VMAT, similar to IMRT. In the table at the bottom, you see some metrics of target coverage and plan quality. So if you're not familiar with the way that we assess a radiation plan, the proton plan on the left side of the screen is doing a better job of covering the tumor bed, but keeping the plan relatively cool and constant across the area treated like you intend, compared to the VMAT plan. And at the same time, while getting better target coverage, it's delivering far less radiation to the child's temporal lobes, specifically the hippocampal heads, as well as the cochlea on the left and the right. So a better plan all around. This is another common pediatric brain tumor. This is a craniopharyngioma treated with a proton plan on the left and an IMRT plan on the right. And you can see just qualitatively the difference in radiation dose to the temporal lobes in the supratentorial brain, for instance. How does this translate into outcomes? In this slide on the left panel of the screen, you see 3 graphs showing the rate of impairment across domains such as task efficiency, organization, and memory across different radiation doses to the temporal lobe. And I brought these color bars over directly from the image of the craniopharyngioma on the right side, and to show you that the steep part of these curves corresponds right around the blue teal area of dose to the temporal lobes. And that's exactly where you see the largest difference in these two radiation plans. So in a child like this with a craniopharyngioma, we expect to see relative gains as they become a survivor in things like task efficiency, processing speed, and memory. Now that's all theoretical data. That's modeling based on radiation dose predictions. We're just now beginning to have some actual clinical data supporting it. So this is a study from 2015 looking at early cognitive outcomes in children with brain tumors. And in it, they looked at 60 patients with brain tumors and measured their IQ across a number of domains at baseline, and then did a follow-up exam across the same domains 2.5 years later. And essentially you can see on the screen that across almost every domain except processing speed, the cognitive function was stable, meaning there was no decline following the radiation. Here's another study of 114 children treated with a variety of brain tumors between 2002 and 2017. In these children, 48 were treated with craniospinal radiation, and that's radiation to the whole brain and the spinal cord for something like a medulloblastoma. And 66 of them were treated with focal radiation, that's just to a specific spot. All were treated with proton therapy. This graph shows their IQ over time, stratified by both the patient's age and the type of radiation they got, whether it was craniospinal radiation or focal radiation. So you see this blue line has a significant drop, and that's the children who received craniospinal radiation when they were less than 6 years old. And that's kind of predictable because whether it's protons or X-rays, when you radiate the whole brain, you're not sparing anything at all. However, 3.5 years later, no significant changes were seen across any older patients, including those who received craniospinal radiation, and no change in IQ was seen in even the youngest patients when they were treated with focal proton therapy, which is really remarkable considering our baseline understanding of the effects of radiation on an infant's brain. Here's another example. This is actually a comparative study, and this looked at 125 children irradiated for brain tumors, median of 7 years old. They looked at univariate and multivariate analysis of predictors of neuropsychological outcomes, and when they compared the patients treated with X-rays to the patients treated with protons, those who were treated with protons had significantly higher outcomes in terms of full-scale IQ, verbal IQ, processing speed, and then multiple other domains of adaptive functioning like social, conceptual, and practical functioning day to day. And this maintains significance even after you controlled for all the other factors we know that contribute to cognitive outcomes in children, such as their age at the time of treatment, whether they got this craniospinal radiation or not, or the presence of hydrocephalus. Proton patients still did better. This is an interesting study because it looked at about 90 patients treated in the 2012 to 2017 era, all who received either proton therapy, except for a cohort of 40 of them that received surgery alone. So you can see in this red line, the patients who received craniospinal proton irradiation did have a slightly significant drop, as you would expect, because of their whole brain radiation. But the patients who had focal proton therapy and the patients who had surgery alone, that's no radiation, had stable IQ. That is to say that protons added cognitive decline beyond surgery itself. So this is some data that we developed in collaboration with St. Jude Children's Research Hospital. And this specific study called RT2CR was a phase 2 trial for children with craniopharyngioma where we used a relatively tight or small target margin. And what's interesting about this effort was we had another phase 2 comparison cohort, and that is children who were treated at St. Jude previously on a study using similar small target margins. Our study had about 94 patients in it. This original St. Jude study had 100. And this data is just now becoming mature. It hasn't yet been published, but presented at a couple of conferences. So first of all, progression-free survival. So at the 5-year mark, the children treated with proton therapy maintain the very high rate of progression-free survival, as we would expect. Overall survival, likewise, is identical. So despite the conformality of proton therapy, we aren't seeing missed targets in this protocol. We also didn't see any increase in severe or new types of toxicity. So the patients treated with proton therapy had the same rate of brainstem necrosis, that is very low, and the same rate of vasculopathy as those treated with X-rays. Now, importantly, we saw, just as the models would predict, that the mean brain dose for the children treated with proton therapy was significantly lower. And that translated into clinically relevant and statistically significant differences in academic outcomes. The reading scores in these patients, the blue line is protons, the orange line is X-rays, was significantly better in the proton patients. Likewise, the mass scores. They're both stable in the proton patients. This is 3-year data. When this 5-year data is mature this summer, it'll be published in a paper. So moving on to endocrine or side effects related to hormone outcomes. On the left side of your screen, you see an 8-year-old child with a low-grade glioma of the right temporal parietal lobe treated with IMRT or X-rays. And on the right side, you see the same patient with a proton plan. One of the first things that jump out at you is the absence of radiation dose to the left hemisphere in the child treated with protons, so you'd expect improvement in neurocognitive outcomes, as I was discussing. But likewise in this patient, the radiation dose to the hypothalamus using conventional radiation is 27 gray versus less than 1 gray in the proton patient. Here's another example of a 4-year-old with a posterior fossa ependymoma. The IMRT plan on the right and the proton plan on the left. Whereas the IMRT delivers 18 gray dose to the hypothalamus, the proton plan delivers virtually no radiation to the hypothalamus. So why does this matter? Why does radiation dose to the hypothalamus even have relevance? Well, this is a table demonstrating the probability of subsequent growth hormone deficiency at 5 years by the mean hypothalamic dose. So that first patient I showed you would have a 25, after 25 gray approximately, would have a 75% chance of growth hormone deficiency if they were treated with X-rays, which would be completely avoided if they were treated with protons. And the second patient I showed you, that number would be at about 40%. Again, completely avoidable with proton treatment. And growth hormone deficiency, we know after radiotherapy or for any reason, is a serious problem and contributes to the obvious impacts on growth, bone loss, disruption of the metabolic system and the autonomic system across the board. So here's the actual clinical data that we have addressing this now. So this study, which is actually a combination of 2 studies presented in 2015 and 16, looked at 106 patients treated with X-rays and 160 treated with protons for medulloblastoma. First, the dosimetric comparison. So what radiation doses did these 2 cohorts get? As you would expect, the patients treated with protons received lower doses to the hypothalamus, pituitary, and thyroid gland. And that translated into clinically relevant reduction, really substantial reduction in the rate of thyroid hormone deficiency as well as growth hormone deficiency. Here's another example patients treated with medulloblastoma. This is a comparative study. It looked at 40 children that were treated with protons and 37 that were treated with X-rays with over 3 years of follow-up endocrine screening. And on a variety of analyses, including multivariate analyses, the children who received proton therapy had a reduced risk of hypothyroidism, sex hormone deficiency, any endocrine replacement therapy, and less ultimate impact on their height. This example below is a combination of two papers, one from a cohort of patients treated with protons at the University of Florida and one cohort of patients treated with protons at MD Anderson in Texas. Of 206 children with low-grade glioma across the two series, there were only 3 instances of endocrinopathy that developed in patients who had tumors that were away from the hypopituitary axis, meaning proton therapy effectively avoided any endocrine consequences. Moving on to radiation-induced second tumors, this is one of the cruel but ironic toxicities of proton or of any type of radiation, where a radiation beam can hit a normal cell and cause it to change into a second totally different cancer in the future. So this is an example of a historical outcome series. Over 1,000 patients with medulloblastomas who received craniospinal radiation with X-rays. So as I was describing earlier, craniospinal radiation involves radiation to the entire brain, as well as the spinal cord and the CSF surrounding it. This is the target here. With X-rays, you treat the patient and the radiation continues to travel and exits through the thyroid gland, the heart, the lungs, the abdomen, the pelvis. And in this cohort of over 1,000 patients treated with X-rays, like the image below shows, the 10-year cumulative incidence of second tumors was high. It was over 1 in 20 children. And when they did an analysis of where these second tumors occurred, the majority of them were in this area, in the area of the exiting radiation dose, which can be completely spared with protons. So one of the arguments is that that traditional X-ray image I showed you didn't take into account some of the more modern types of radiation delivery, things you might have heard about like IMRT, VMAT, tomotherapy. This paper was published just last year that looked at the conventional traditional radiation, the other advanced types of X-ray based radiation, and proton therapy. And proton therapy was still associated with a 2 to 3 times reduction in the risk of second malignancies compared to X-rays. This is another way to look at that same data and same risk. This study tried to get at what radiation dose is important in the creation or genesis of second radiation tumors. So this Scandinavian group looked at children who had received radiation to their whole brain for childhood leukemia. And the table to the left specifies the number of patients age 8 and younger with the number of subsequent meningiomas in parentheses. So here, by the radiation dose they received. So 2 things I'll point out in this data set. The first is that most of the radiation-induced meningiomas actually occurred in patients who received between 21 and 25 gray. Can't really explain the reasons why. But in this dose range, radiation-induced meningiomas were actually quite common. 1 out of 3 survivors developed a radiation-induced meningioma with the years of follow-up. So taking you back to that craniopharyngioma example, again, I show you here what is this 21 to 25 gray dose range. It's right in the kind of teal, light blue color, and that's exactly where you see the difference, the substantial difference in radiation dose between these 2 patients. So you'd expect to see less radiation-induced meningiomas and the child on the right. So it's really, really tough to gather data on second radiation-induced tumors because, number one, fortunately, they're still quite rare. And number two, you need to follow patients for years, at least 3, 4, 5 years. It's especially hard to do in children because the incidence of pediatric brain tumors is still relatively low. The best data we have addressing this topic comes from this really large study that was presented at ASCO last spring of primarily adult patients treated across the United States with traditional X-ray-based radiation, advanced X-ray radiation called IMRT, and then proton radiation. And across the cohorts, the same median follow-up, and it's a huge data set with cumulatively over 2.5 million person years. For all three types of radiation, the majority of the tumors treated, like I said, it was adults, so it was pediatric or breast cancer. And the bottom line is with this large, thousands of patient group, proton therapy was associated with a 0.3 times risk of second radiation-induced tumor, a very substantial reduction in the number of second tumors observed. And although this cohort was largely adults, when you look at the age range, it seems evident that it doesn't matter what age range you're looking at, you're going to see a decrease in second tumors. So finally, moving on to quality of life outcomes. This is a little bit more difficult to measure, but nonetheless important. So first of all, acute and subacute toxicity, how it contributes to quality of life. This is a comparison of prospective data for children with pediatric low-grade gliomas. In two combined studies, one from the University of Florida and one from St. Jude, we looked at nausea requiring important antiemetics. And we found that in an X-ray series, 70% of these children required antiemetic medication, whereas only 13% needed it following proton therapy. And for those patients who had ongoing side effects, nausea, severe problems following radiation, they required corticosteroids. About half of the patients with low-grade gliomas treated with X-rays required steroids, whereas it was less than 10% in those treated with protons. This study looked at health-related quality of life in pediatric patients treated in Stanford and Boston that were matched and prospectively collected using the validated PEDS QL scale, a measure of quality of life. And they found among these two cohorts that patients who received proton therapy reported better physical health-related quality of life, better psychosocial health-related quality of life, and better overall health-related quality of life. And the difference in the scores were actually quite dramatic. And related to this somewhat is fertility outcomes. And there's not a ton of data on this, but I wanted to show you this one example, this case report. This is an 18-year-old young woman, who was treated with radiation alone for a disseminated germinoma. She required 36 gray craniospinal radiation. So in this craniospinal X-ray radiation plan here, what's often done is you take these young women to the OR and you do an oopexy, which is intended to move the ovaries outside of the radiation field, kind of to the lateral aspects of this radiation field. And in some ways it's effective. So you can see here, it reduced the maximum dose and the mean dose to the ovaries somewhat. However, the uterus is still there, it's not moved, and that still gets a radiation dose as the lower spine fields exit here. What they did is they took this same patient and they said, well, what if we had treated her with proton therapy? Well, it turns out that the dose to the ovaries would be virtually 0, and the uterus dose would be virtually 0, and you didn't even have to move the ovaries. It didn't make a difference whether you had the ovaries in their original spot or not. The radiation dose was still negligible. So you expect the fertility in this patient to be better following survivorship of this germinoma. So I'd like to conclude with just a few slides on some of the foremost common misperceptions about proton therapy. And I hear these wherever I speak. The first misperception is that we have all these dosimetric models. Those are all the pictures I showed you showing radiation doses, but there are no clinical outcome data in children. And you see, fortunately less so now, but about 5 or 10 years ago, we would see articles or editorials with titles like this, a new fad or standard of care, proton problem. In fact, about 5 years ago, this meta-analysis of the data was critically reviewed in the main journal of our specialty, and the authors concluded that the long-term effectiveness and harm associated with proton therapy across the 15 different cancers that they looked at was, their word, lacking. So here's the reality. If you want to get a very rough estimate of data on radiation in children, you can do a PubMed search like I did. And if you do a search of just broadly pediatric cancer, proton radiation, you come up with almost 400 published articles. If you do that same thing, pediatric cancer IMRT radiation, which is broadly accepted in pediatric cancer, you find less than a third of the published articles. So if one is willing to accept that IMRT is appropriately evidence-based, then you would certainly agree that proton radiation is evidence-based. Now you could argue, well, maybe all these published articles are just dosimetric modeling studies, physics studies. So it's very easy. You can do a search for pediatric proton radiation outcomes, and you find over 100 articles. If you do the same thing with IMRT, you only find 18. So the evidence for proton radiation is actually quite robust compared to other examples. In fact, today, the largest series describing the outcome of radiation therapy, any type of radiation therapy for pediatric ependymoma, craniopharyngioma, and low-grade gliomas, were actually studies that were carried out with protons. And if you just quickly search the literature, there are now peer-reviewed outcomes published for a whole variety of pediatric brain tumors and non-CNS brain tumors listed here, in addition to a number of papers on acute toxicity, late toxicity, and some of the quality of life studies I showed you. And gratefully, a couple of years ago, another review was done of the published literature, this time in Cancer Treatment Reviews, and these authors concluded that the current evidence surrounding the use of proton therapy supports its effectiveness and benefit in reducing the incidence of severe toxicities in later life. So the data is becoming a little bit more prevalent and agreeing with the dosimetry. So misperception number 2, quickly, a lot of concerns you would hear is that the high conformality, that is the precision of proton therapy, would be detrimental in disease control because it would miss the tumor and be associated with a higher risk of disease recurrence. So this just hasn't borne out in the actual clinical outcomes across a number of different studies, including like the craniopharyngioma data I showed you. The tumor control rate is just as good or better with protons. Wrapping up shortly, proton therapy is too expensive. There's articles like this a few years ago, why are healthcare costs exploding? See proton cancer therapy. The reality is that yes, proton therapy up front can be more expensive than traditional radiation, sometimes twice as expensive. But when you add up the cost to the patient and society over their lifetime, like things of growth hormone replacement, those examples I showed you earlier, that can be 10 to 30,000 US dollars per year. If a young woman gets radiation to her pituitary gland and requires hormone assistance for fertility, that can cost easily over $10,000 per pregnancy, and in the United States, that's not covered by any insurance. You think of other endocrine hormone replacement therapy that patients need. Over the course of their lifetime, it's thousands and thousands of dollars for the healthcare system. And that's not even considering the cost of treating these extra second malignancies that might develop, cardiac disease that might develop, hearing loss. It adds up over a lifetime. So to look at this from a more quantitative standpoint, this is an article published by a team from Europe, and it looked at the cost effectiveness of proton therapy for a child with medulloblastoma, specifically looked at a number of different endpoints, things that I mentioned, like second cancer, hearing loss, IQ effects, hormone deficiencies. And they found that over the lifetime of a patient, the use of proton therapy actually reduced the total cost to the healthcare system by almost 25,000 euros. And not only that, it was associated with a better quality of life. So the authors concluded that for a child with a medulloblastoma, proton therapy is not only effective, but also cost effective. A similar article was written by one of my colleagues at UF looking at the same topic or same issue within the United States reimbursement system. And one way to measure cost effectiveness is the pay threshold for one quality adjusted life year. So essentially in the United States, economists have gotten together and say, if a therapy can provide one good year of survival for $50,000, it's considered cost effective. No matter what type of medicine or no matter what industrial domain. This study showed that proton therapy cost society less than $5,000 for each quality adjusted life year it improved. So let's put this in some context. I talked about proton therapy in a pediatric medulloblastoma. You pay less than $5,000 for each quality adjusted life year you gain. In the United States, if you do this analysis on the cost of a car airbag, you end up paying 120,000 US dollars for one quality adjusted life year. Bringing it to the cancer realm, I don't know if you're familiar with it, but these things called tumor treating fields are often utilized and advocated for adults with high-grade brain tumors. In that case, you have to pay $394,000 for one quality adjusted life year. And the cost of adding chemotherapy drug, bevacizumab, second or third line therapy in a colorectal cancer patient costs $1.2 million for one quality adjusted life year. So certainly if society, if we're saying that these things are worth our dollars, proton therapy would be a bargain. And that's actually represented in these other analyses published as recently as 2016. So finally, the use of proton therapy in pediatric cancers is based on secondary motives of financial gain. Well, this doesn't really hold up, unfortunately. This article was published a few years ago by Peter Johnstone and a colleague. And what they looked at and what is demonstrated in this figure on the left side of the screen is the number of complex or pediatric cases treated at a proton center across the net expected revenue. So essentially, no matter what kind of model you look at, you treat more pediatric cases and you make less money. So there's actually a disincentive financially to treat pediatric patients. Now this is United States data, but a very similar study was done in Europe. Found the same thing. So the bottom line is that children derive no benefit from the radiation of normal tissue. We knew that long before proton therapy. And proton therapy can therefore be used to reduce the amount of normal tissue that receives collateral radiation. And current clinical data, particularly stuff published over the past 5 years, has effectively substantiated the models, the dosimetric models of benefit. And it's important to remember that the magnitude of benefit, both from a clinical and financial standpoint, will vary depending on the patient and clinical circumstances at hand. So a lot of this is dependent on choosing the patients who would benefit most from proton therapy, like pediatric brain tumor patients. With that, I'll say thank you.
Thank you so very much, Danny, for this very informative talk. I think it's very convincing, at least for me. So, any questions from the floor? I think they touch on the justification of the proton therapy, but I think when we start working, we need to know the nitty-gritty of the planning, the assessment, and also the care. I think the difference between the pediatric and adult patient is the preparation, sedation, how they accept the therapy, etc. So I think there would be plenty of reason we need to invite you back again to Hong Kong, or maybe
sure, I'd be happy to
sharing some of the information through the internet,
sure.
Web discussion. For information, this talk is webcasted to all the HA hospital, 43 HA hospitals. So I hope that after this talk, some young doctors will be inspired and they would like to pursue on developing proton therapy techniques and expertise. So any questions from the floor? Oh, Dr. Ha.
I'm a pediatric oncologist. Just wonder,
Yeah.
so we have heard many good points about
Yeah.
proton therapy, but I just wonder whether there would be some specific tumor that's contraindicated, or maybe relatively you don't want to give this proton therapy, such as a brainstem glioma
That's a
that
good
the
example.
patient may not survive for a very long time. So any kind of specific indications or, or contraindications?
Yeah, so that's a great example. Brainstem glioma, sadly, no matter how much radiation and no matter in which fashion we deliver it, those children are not going to live long enough to derive a benefit from proton therapy. They're not going to be 10, 20-year survivors where IQ matters. So in that situation, there's really no difference in the delivery of radiation between the two. Another example, a little bit less intuitive from a physics standpoint, is when the intent is to treat large areas. So some patients require whole abdomen radiation or whole lung radiation. In that case, the precision of proton therapy is not as valuable as it would be in a tumor sitting next to the cochlea or the optic pathway. We're looking at ways to use proton therapy for some of these broader targets to avoid maybe the heart or the kidneys, but definitely when you talk about magnitude of benefit, it's lesser in that type of case. And there's other situations, such as a child with metastatic disease in bone mets. Like if you're radiating somebody's thigh and they're only going to live 4 more years, 4 more months, there's no advantage to proton therapy.
So any more questions?
Yes, Danny. May I ask
Mr.
you
Lee.
what is the average cost, for delivering one of these proton therapy?
In U.S. dollars, I mean, I have no idea how it would translate into other economic markets. But in the United States, it'll cost for an average treatment, which is 6 weeks, about $80,000 to $100,000 in a child who doesn't require anesthesia. If they require anesthesia, the costs go up like another $50,000 because it's 6 weeks of daily anesthesia. And then you look at things like patients who need concurrent chemotherapy, other ancillary tests or therapy, and it can get you to $200,000. On the other range of the spectrum, just to put it in context of the overall patient load, if you have an adult with a brain tumor, an adult with a prostate cancer, for example, the charge might be more like $50,000. But again, that's in the crazy health economic system of the United States and insurance companies. I have no idea how that translates outside. Yeah.
I think one of the reasons I'm intrigued by this talk is that although I'm not an oncologist, but we get asked by many parents, our friends, etc., about when you have a child with tumor, with cancer, they ask for all kind of treatment options, and I think in the news we heard that one of these kids actually got to Taiwan to get the proton therapy. So I think as pediatrician we need to know at least the basics. But for the reason I stated earlier in the introduction, I think we need to work further with you and also with the team from Florida and Hong Kong Sanatorium, Hospital and Sanatorium. So with that, I'd like to thank you. Oh, there's another question from
very short question.
Yeah.
Just for interest of, besides the indication of cancer, how about of the epilepsy surgery? There's a foci for epilepsis.
Yeah.
So if you use the proton therapy, does it work as well instead of surgery?
Yeah. So
any clinical
that's an excellent question. People are using focused radiation, focused X-ray-based radiation to ablate nidus for epilepsy, and that's kind of at the incipient early stage. If you follow the logic, you could definitely do it more precisely with protons, just because of the differences in dose distribution. But nobody has carried out those studies yet with proton therapy.
So I can comment on that. So I'm Phil Aldan, I'm a neurosurgeon. So the data for efficacy to treat or ablate or cure epilepsy was with non-pharmacologic means. So modalities other than medicine. Surgery by far is still the gold standard in terms of cure rates. There are some newer technologies, for example, like laser ablation that's used for specific types of epilepsy. Stereotactic radiosurgery for treating epileptic foci has been tried, but the data is not as good as surgery. Yeah. Okay. And it's probably cheaper to do surgery than protons.
So thank you very much. Thank you very much, Danny. This is a little souvenir from our SIM Center to you. Great. And it says, together we keep learning the thing we seem to know. Unfortunately, we seem to know nothing about proton therapy. So thank you once again for coming to Hong Kong and then share your insight into this new treatment modality for children with brain cancer. Thank you so much. Okay.